Good. So about all of these, just a couple of comments. They're all very similar, and there's 13 others. They're marking proliferation as the top predictor of aggressive disease. They're marking lack of hormone receptor expression as a predictor of aggressive disease, and they're marking HER2 positivity as a predictor of aggressive disease. After these main pathways, the other pathways are supportive, but not as determining as those three important ones. But we can still worry that by overfitting the data, by having too many genes in our test and not enough patients, we can get false conclusions with all sorts of bias and not able to generalize to whole large patient cohorts. So we still have challenges for this multi-gene-based testing. Comment about TOPO2. I get asked this all the time. Are we ready? Is it coming? Should we do it? And what for? And the answer is, I don't know, and I don't know. I've been looking at it and following it for more than 10 years. It comes in, it goes out. 1 minute we see you shouldn't use anthracyclines and TOPO2 negative, then you realize we're not using anthracyclines for anything. So in breast cancer, is TOPO2 testing to become commonplace? I don't think so. Firstly, you can't do the protein-based test, which we see here, compared to this is the CISH-based test, which you can do, FISH, for gene copy number. TOPO2 is a cell cycle expressed protein, and all cancers will express it at certain stages of the cell cycle. So your IHC test isn't telling you what the actual TOPO2 index is, it's just telling you what stage of the cell cycle your particular cell is in. The gene copy number, though, reflects amplification. But the problem is, TOPO2 amplification occurs virtually only in HER2-positive breast cancer. You don't see it as an isolated event. The two genes are very close. There's only a few base pairs between them on chromosome 17. And about 35% of HER2 amplified is also TOPO2 amplified. So here's the patient cohort you think might have an unusual benefit from anthracyclines. And if you remember way back to the 1994 when Hy Mus published in the New England Journal the paper that said IHC-positive HER2 breast cancer got benefit from anthracyclines, he was really probably showing that those were HER2-positive tumors as well that also had TOPO2 gene amplification. He did use IHC. Well, here's the reason. If anthracyclines are dangerous to use because you want to use trastuzumab to protect the heart against cardiotoxicity, the very patients who are going to be TOPO2 positive, you've already decided you don't want to use anthracyclines anyway. So what's the point of doing the test? To find out that you have an indication for a therapy that you've already decided is contraindicated. So I don't think, for that reason, TOPO2 gene-based testing in breast cancer is likely to become commonplace. But there are some who do believe it will. It's an easy test to do. We'll do it if there's a need for it, but right now I'm doubtful. And finally, in breast cancer, the circulating tumor cells. What an interesting saga. A test that clearly has shown it can do what it says it can do, but hasn't gotten massive clinical acceptance yet. And why is that? I think firstly, despite study after study after study, which shows as a prognostic test, it cannot be competed against. If you have circulating tumor cells with your breast cancer, more than 5 per 7.5 ml of blood, that is an adverse prognostic factor. And if after therapy or during therapy that number doesn't reduce, that's a very serious adverse prognostic factor. The question is, we have prognostic factors that exist for breast cancer, and do we need another one? Maybe we do, maybe we don't. The real potential value for circulating tumor cells is twofold. Number one, we could use them to guide therapy change in a non-responding patient. And number two, we could do tests on cells we captured in blood that would teach us new things about the patient's disease and then custom design the therapy based on those results. So for the first idea for using it to change therapy, it's all based on the SWOG 0500 trial with Dan Hayes as the principal investigator. Patients are randomized to get cell search-based circulating tumor cells versus not. Those who do get the cell search test, if the frontline chemotherapy fails to reduce the circulating tumor cells under 5, the patients are switched to a second-line therapy. Patients who don't get cell search are switched to second line when clinical assessment judges that they've failed first line and it's time to change. Using disease-free survival as an endpoint, will the test lead to earlier therapy change leading to prolonged disease-free survival in the test group versus the non-test group? If that occurs, I think that would be a very important finding for using circulating tumor cells more broadly. If instead it doesn't show a benefit, to know that you failed to reduce the number, that would probably significantly inhibit it. And let's see, I'm not going to go into the other methods right now, but here's the concept of trying to do testing of circulating tumor cells for biomarkers that might be very important predictors of how the metastatic disease will look or does look. And the one test that's firstly being looked at is, can you perform HER2 testing on circulating tumor cells? And a number of studies, mostly almost exclusively now only published in abstract form. And this taken from the Immunicon, which is the parent company that developed the test. It's marketed by Johnson & Johnson, Veridex, I'm sure as you know, shows, in which here with a series of breast cancer captured cells proven to be epithelial with their fluorescein conjugate anti-cytokeratin in immunofluorescence test, that these tumor cells on occasion can be shown to express in red the rhodamine conjugated anti-P185-NU, the HER2 immunofluorescence, and here a complete membranous encirclement, HER2 membranous overexpression. And although the fish didn't come out great, this particular cell, which isn't overexpressing the protein on the surface, has 4 copies of HER2 in red and 4 copies of chromosome 17, so it's a tetraploid cell, but it's a 4/4 or a ratio of 1, meaning non-amplified. This one with some HER2 on the membrane, but not completely encircling, has 1, 2, 3, 4, maybe 5 HER2s to 2, might be a 2.5 range ratio. And then this one with robust has a cluster of HER2 signals here and 1, 2, 3, 4 others, so it's probably an amplified cell. Now, I don't know whether these cells come from HER2 negative or positive primary tumors. The big question these studies have suggested is, could a patient who primary tumor tested HER2 negative have a HER2 positive circulating tumor cell result that would be useful for adding a targeted anti-HER2 therapy, lapatinib or trastuzumab, which originally was not being used? And there's no answer for that now. There's been no prospective trial using CTCs as a reason to add or to change therapy because they're expressing HER2 when the primary didn't. I mean, we'd all like to see more positive patients to treat, since we're impressed with the results of treatment in the patients we already are detecting on the primary tumor. And this has promise, but it requires large numbers of patients to validate it, and it's not an easy test to do. It's not clear what's the best technique to do, whether it should be immunofluorescence for the protein or FISH for the gene copy number. And we're not also certain whether or not it will be biologically significant in terms of predicting trastuzumab response. But it's possible. And that leads this to become a test of keen interest. There's a couple of other emerging HER2 negative tests that might make a tumor trastuzumab eligible. I didn't bring slides, but the one that I've been interested in is this new regulin expression, a ligand for HER4. When the tumor cells make it themselves, they autocrine stimulate the HER4 by ligand binding, which then dimerizes with HER2. Well, trastuzumab has a anti-HER2 HER4 binding or dimerization mechanism. One British study on a small number of patients showed that HER2 negative, no gene amplification, FISH negative, cases that had an IHC positive for neuregulin, when treated with trastuzumab, had the same benefit as HER2 positive did. They got about a 27% response rate in the metastatic setting. So it could be someday that we capture some more patients for trastuzumab, or this would be trastuzumab because I don't think the lapatinib wouldn't work on this one, for patients who are HER2 negative on the first test, but now we got a next test we do to capture a couple of more patients that we could still treat because of this other way HER2 is activated and the antibody would work. These are interesting